Ethics is the matter in us. It is in every form, it is in every act, every deed, and every thought, be it our daily course, be it a clinical practice or research. I take this honor and pleasure to invite for today's session Dr. Sanjay Nagral to chair the session on the KR Memorial Lecture by Dr. Eric Suba. He is a surgeon with specialization in hepatopancreatobiliary surgery and liver transplantation. He practices in Mumbai both in public and private sector. He is the coordinator of Department of Surgical Gastroenterology at Jaslok Hospital and the head of Department of General Surgery at KB Bhabha Municipal General Hospital. He was involved in the first successful liver transplant program in Western India. He is the Joint Secretary of the Zonal Transplant Coordination Committee based in Mumbai and the chairperson of its liver committee. He is the publisher and member of the editorial board of the Indian Journal of Medical Ethics and the chairperson for the Forum of Medical Ethics. He has over 100 publications in his peer-reviewed medical journal to his credit. He is also involved with the Jan Swasthya Abhiyan, which is the Indian circle of the worldwide people health movement. We welcome you, sir, and ask you to conduct the proceedings further. Thank you.
Thank you very much. You hear me? Is mic working? Okay, so first of all, let me say that I consider it a matter of great honor and privilege that you have asked me to chair today's oration. In fact, when I was first asked to come and chair this oration, I had some doubts as to whether I really qualify for this job. But I accepted, and I accepted for two reasons. The first, of course, is the fact that I missed no opportunity to come back to this institution where I spent almost 20 years of my life as an undergraduate student, then a postgraduate student, and then, of course, in the faculty of the Department of Surgery. But I think the second more important reason why I chose to accept this and be here today is because of the bond that I have shared with almost all the players that were present in today's meeting. So starting right from Krishna and EPW. I did know Krishna very well. I met him only once, but in the last 5 years I've been writing regularly for EPW. I did a blog for them. To all the organizations that are involved in today's meeting, of course the GS Medical College, KM Hospital, Tata Hospital, I spent a year, and Dr. Padve was at that time leading a lot of path-breaking work in breast cancer. The Sehat, who is the main organizer, and I have been witness to the birth and growth of Sehat over many years. E-Social Sciences, SNDT, and of course the Forum for Medical Ethics, which was founded in this institution. Some of you would be interested to know, by Dr. Sunil Pandya, who was the then head of neurosurgery in this institution, who founded this small little journal called Indian Journal of Medical Ethics, which has now grown to its current predominant position. So I am now going to introduce to you the person, Dr. Eric Suba, who is going to deliver today's oration. And I'm going to sort of, most of you have a sense of his background, because I think you have been given some material on Dr. Suba, his background and his training and his interest in the area that he's going to talk about today. So primarily, he's a pathologist, the director of the clinical laboratories at the Kaiser Permanente Medical Center in San Francisco, which I am, perhaps, am I right in saying that one of the largest managed care health groups in the United States. Dr. Suba, incidentally, has had an interest in cervical cancer for many years. Firstly as a researcher, and then, of course, as a very close observant and critique of the way research has been conducted in this area. He led for many years the Viet American Cervical Cancer Prevention Project, an all-volunteer non-profit organization which was founded in 1996. And subsequently, this organization implemented the Papanukulu, or the PAP cytology screening services in southern Vietnam. And just before the lecture, I asked Dr. Suba as to why Vietnam. And the answer he gave me was interesting. He said that he thought that he owed it to them. So a lot of interesting historical perspective here, where a group of researchers from the United States decides to go to Vietnam and do some path-breaking and ground-level research in a problem which the Vietnamese faced and which many of the other developing countries of the world continue to face, which is cervical cancer. Dr. Suba, of course, also has a commitment to rapid, effective cancer prevention, and he has been, as you will see in today's oration, a critique of what he calls US taxpayer-supported studies of cervical screening in countries including India. Dr. Suba recently has been appointed as a visiting scholar at the National Center for Bioethics at the Tuskegee University in Alabama. Now, some of you would know that this town in Alabama was the center of the infamous Tuskegee study, which is a study done on Afro-American men with syphilis, in which many of them were just put into what at that time was called observation. And later on, this was a subject of a huge controversy in the United States, which had ripples all over the world. And in fact, in 1997, President Bill Clinton actually issued a presidential apology to the victims of the Tuskegee study. And that's something that perhaps we should be aware of. So today's oration by Dr. Suba is provocatively titled, "The Golden Rule, a Remedy for Decadence in Global Health." When I was reading through some of the writings on this subject in preparation for today's, my attempt at today's introduction, what struck me was that the topic that he's going to cover today actually touches perhaps one of the widest spectrums of discourse, various discourses that impact on healthcare. So it's about science, it's about economics, it's about public health, it's about ethics, it's about gender, it's about class. And before I hand over the mic to Dr. Suba, I must say that this is exactly the kind of interdisciplinary, intersectional area that would have definitely excited somebody like Krishna Raj. And in fact, EPW is perhaps the best example of a publication which has attempted over the years of its existence to involve all the disciplines in one of the best, I would say, publications of that sort, at least in this country. So with these words of introduction about Dr. Suba and his topic for today, may I now welcome Dr. Suba.
Thank you for that kind introduction. And I'd like to express my most sincere gratitude to the King Edward Memorial Hospital and AT and CHAT, IJME, and all the other conference organizers for offering me this honor and this terrific opportunity to speak to all of you today. And to each and every one of you, thanks for coming this afternoon and taking the time to come and hear what we have to say and discuss. In terms of disclosures, I have no personal relationships with any of the commercial interests relevant to this presentation. But I am an American taxpayer, and as such, I've indirectly contributed money to the studies that I'll be discussing today, and for that I sincerely apologize. I also have to disclose that I've submitted allegations regarding the Tata Memorial Study to the U.S. Office for Human Research Protections and to the U.S. Office of Research Integrity, and I'll have more to say about that later. First, a little background information. This is a cartoon illustrating how cervical cancer comes about. Cervical cancer begins with infection of normal cervical tissues by human papillomavirus, HPV. In less than 1% of cases, HPV infection becomes cervical cancer over a period of many years, 10, 20, 30 years. And during the 10, 20, 30-year period between initial HPV infection and the onset of cervical cancer, the cells of the cervix undergo characteristic changes called dysplasia. And dysplasia is another term for a precancerous lesion of the cervix. Cervical screening prevents cervical cancer and lowers cervical cancer death rates by detecting and treating these precancerous lesions before they develop into cervical cancer. So the goal of screening is to use this 10-year, 20-year, 30-year window of opportunity to detect precancerous cervical lesions and to treat them effectively. There are 3 established methods for detecting precancerous cervical lesions. Visual screening tests, abbreviated as VIA, were introduced into routine clinical practice in the 1930s. Pap smears were introduced into routine clinical practice in the 1940s, and HPV tests, human papillomavirus tests, were introduced into routine clinical practice during the 1990s. Each of these 3 methods, used correctly, is an established and effective way to prevent cervical cancer and reduce cervical cancer death rates. Here's an outline of the 3 studies I'll be discussing today. The first of these 3 studies began here in 1997 and ended in 2015. It was conducted by Tata Memorial Hospital with funding from the U.S. National Cancer Institute. The second study began in Osmanabad in 1999 and ended in 2007. It was carried out by the World Health Organization's International Agency for Research on Cancer with funding from the Bill and Melinda Gates Foundation. The third study was conducted in Tamil Nadu by the International Agency for Research on Cancer, which is often referred to as IARC, also with funding from the Gates Foundation. All 3 of these randomized trials compared cervical cancer incidence rates and death rates among large groups of women who were offered cervical screening to incidence rates and death rates of cervical cancer among women offered no screening whatsoever. And as I hope to explain, the use of unscreened control groups and death rate measurements was scientifically unnecessary and resulted in deliberately allowing human beings to die merely to contemplate questions that had already been answered. I think we'd all agree that this is not a good place to be. And the other part of my lecture today is I wanted to propose that we move from this place to what I call the golden rule, and that leaders of important institutions embrace the golden rule and assimilate the policy implications of that ideal. The Delphi exercise is the method that I'll propose that we use to move from the status quo to a more hopeful future. This is a graph showing the effect of Pap smears on 2 different communities, the United States and southern Vietnam. In the first half of the 20th century, cervical cancer was the #1 cause of cancer-related death among American women, which is the situation in many low and middle-income countries today. The introduction of Pap screening to the United States led to dramatic reductions in cervical cancer incidence rates. My own experience in Vietnam began in 1994 when I traveled there and began relationships and friendships with the cancer care community there. In 1997, maybe with some encouragement from me, the vice presidents of the Vietnamese Cancer Society, which is the organization in Vietnam that has explicit authority to formulate cancer control policies for the country, the leaders of the Vietnamese Cancer Society committed to Pap screening for the prevention and control of cervical cancer in Vietnam. And between 1998 and 2003, cervical cancer incidence rates declined by about 50%. There's nothing mysterious about that. The U.S. Preventive Services Task Force is the closest thing that the U.S. government has to an honest broker of information about preventive health services. And the Preventive Services Task Force has determined that the introduction of cervical screening to previously unscreened communities reduces cervical cancer rates by 60% to 90% within 3 years, and that these reductions of mortality and morbidity are consistent and dramatic across populations. Cervical screening and no smoking are 2 of the very few interventions to get an A recommendation from the task force in the absence of randomized trials confirming effectiveness. To compare, mammographic screening gets a B recommendation from the task force, and PSA screening for prostate cancer gets a D recommendation. In 1984, the Imperial Cancer Research Fund concluded that with the exception of no smoking, cervical screening offers the only major proved public health measure for significantly reducing the burden of cancer today. In 2004, I published one of my early objections to the randomized trials happening in India. I pointed out then that contemplating questions that had already been answered had practical implications. That if any of the no screening arms in any of these studies concluded that cervical screening did not reduce cervical cancer death rates, that conclusion would not be believed by anybody and would not be extended to, or would not be generalized to any settings outside of the study settings. I also maintained that if the death rate measurements in the intervention arms showed that cervical screening did reduce cervical cancer death rates, that conclusion would be considered trivial and unimportant. And so I argued that there was just no reason to be doing these randomized trials with unscreened control groups and death rate measurements. What's more, I was under the impression that policymaking in India and efforts to implement cervical screening in India were being delayed pending the completion of these randomized trials. And I pointed out that no one unaffiliated with the tobacco industry has suggested delaying lung cancer prevention efforts pending completion of randomized trials comparing smoking and no smoking. And in 2004, I published my first call asking that women enrolled in no screening arms of these randomized trials be reassigned to screening arms without further delay. A month after this article was published, I went to Lyon, France, to co-author a handbook on cervical cancer screening at IARC headquarters. That's me in the background, and there's Dr. Sankaranarayanan. And I circulated a copy of this article to every person in this picture. And then during the plenary session, where Dr. Sankaranarayanan, where his data from India was being discussed, I asked the collected group that I pointed out that readers of our handbook might have questions about why an unscreened control group was used in these studies. And I suggested that we include an explanatory paragraph to answer those questions to the readers of our handbook. And that suggestion was dismissed without discussion, even though before the plenary session I had private conversations with other co-authors who shared my concerns. The co-authors who in private agreed with me would not come forth in the plenary session to help move my proposal forward. And I'm telling you this story just to point out how difficult it is for a lot of experts to express their true feelings when it comes to controversial ethical issues in the field. That the concern about negative impacts on professional advancement are real and significant. My most recent call to offer screening to the unscreened was published in IGME in 2014. And in that publication, I also called for compensation to the women in the studies who suffered avoidable harm and death. Before I go further, I'd like to take a big step back 20 years to 1996, and before any of these randomized trials started, to give a snapshot of where things were then. And this is a publication by a group that included physicians from Tata Memorial Hospital and, of course, Dr. Sankaranarayanan. And this is a study of an intervention called downstaging in India. And the conclusion of this study was that it's highly unlikely that unaided visual inspection, which means downstaging, could be a useful procedure for the control of cervical cancer. Furthermore, the logistics of visual cervical inspection are considerable and may not be that much less than implementing routine regular cytology screening. Now, when you take these two observations together, you think, well, if that's the case, why not just roll up our sleeves and start doing cytology screening in India? In Vietnam, the leaders were assessing the same information and came to that conclusion, and in 1997 committed to Pap screening in Vietnam. And an important question is, how did we get from this mindset to a mindset where 15-year randomized controlled trials were initiated the following year? And to help understand that, I'd offer the explanation of what I call a zombie invasion. Now, I don't know how many people here watch as many horror movies as I do, but zombies are recurring characters in horror movies. They're humanoid creatures, and their most distinguishing characteristic is they're impossible to kill, or nearly impossible to kill. You go after zombies with shotguns and axes and chainsaws, but they keep coming. No matter what you do, they keep on coming. Paul Krugman is a Nobel Prize-winning American economist. I like to think that he and Krishna would have been good friends. For all I know, they were, but I don't know if they ever met each other. And Paul Krugman has his own personal version of an economic and political weekly. He writes twice a week a column in the New York Times. And it's from several of Paul Krugman's columns that I learned the idea of a zombie argument. And a zombie argument is an argument that's proven wrong. It's been proven wrong many times. It should be dead. It should have died a long time ago. But it keeps lurching forward because it serves a political purpose. The argument that Pap screening is not feasible in countries like India is one such zombie argument. Its political purpose is to serve as kind of a philosopher's stone, to transmute public health interests into research and commercial interests. Think of it this way. Let's assume, for the sake of argument, that the zombie argument is true, that Pap screening is not feasible in India and countries like India. In that case, research and development of alternatives to Pap screening are fundamental humanitarian necessities. And so research into, for example, HPV vaccines and HPV tests become front and center fundamental humanitarian necessities. On the other hand, if this argument is false, which it is, and if Pap screening is actually feasible in India and in countries like India, then all that research into, for example, HPV vaccines and HPV testing starts to look a lot less like humanitarian necessity and a lot more like exploitation. For that reason, this zombie argument keeps lurching forward. The most powerful performance-enhancing drug for any zombie argument is money. And in 1999, the Gates Foundation established the Alliance for Cervical Cancer Prevention with a gift of $50 million. The alliance includes 5 nonprofit organizations, including IARC and a group called PATH in Seattle. The alliance's central founding assumption is that anything but Pap screening was the most likely solution to the problem of cervical cancer in developing countries. So the power of the Gates Foundation got behind the zombie argument that Pap screening is not feasible in developing countries in 1999. And the results were profound and immediate. Here are a couple of examples of zombie arguments that I'd like to show you. These 2 quotes are from the same issue of a bulletin of the World Health Organization in, I think, September of 2001. This is from an article by Mike Trengi and colleagues. This is like an 8-author paper. The authors were physicians from countries in East, Central, and Southern Africa, from Sub-Saharan Africa. And they wrote that 95% of institutions at all healthcare levels in East, Central, and Southern Africa had the basic infrastructure to do Pap screening, but only a few women were actually being screened. In other words, they were saying that Pap screening was feasible, but the political will to do it was not there. In the same issue, Dr. Sankaranarayanan, who is the chief of cancer screening at IARC, contradicted the view of the African leaders and said that, in our view, many low-income countries, particularly most of those in Sub-Saharan Africa, have neither the financial and manpower resources nor the capacity in their healthcare services to organize and sustain screening programs of any sort. Now, I like to think that people who actually are writing from the country they live in have a better sense of what's feasible in their own backyards. But the zombie argument contradicted that. And as it turns out, it's the zombie argument that prevailed in this case. My favorite example of this zombie argument is a comparison of these two quotes. In 2005, speaking of the Osmanabad study, Dr. Sankara Narayanan wrote that our results clearly show that good quality cytology can be implemented even in the rural country, even in a rural setting of a developing country, i.e. India, with reasonable investment. So you'd think that this would kill the zombie once and for all. But even as recently as 2014, he is writing again, the fact that population-based cytology screening is not feasible in India is not our invention. Now, if this top quote had been written 9 years after the bottom quote, it would make sense. But to have this written 9 years before this, as you can see, makes this a zombie argument. So let me talk about the first of the three RCTs, the Tata Memorial Hospital RCT. This is a publication from 2014. And note that it leads as it must with the zombie argument. Because pap smear screening is not feasible in India, we need to develop effective alternatives. Now, as we've seen, the goal of cervical screening is to detect and to treat precancerous cervical lesions before they progress to cancer. And because that's the mission of cervical screening, the single most important quality of any cervical screening test is its detection rate for precancerous lesions. If the detection rate of a cervical screening test is 0, then the test is worthless. And you want to maximize that detection rate. Here are the numbers from the Tata Memorial RCT. And for years I puzzled about this. Dr. Shastri at Tata Memorial conducted a study in Mumbai that was published in 2005 using VIA as a screening test. And he found in that study that the detection rate for precancerous lesions was 0.9%. And 0.9% is a very close figure to other studies that have been done in India using VIA and cytology screening for the, as a benchmark for precancerous lesion detection rate. In 2010, when the first publication came out from reporting detection rates from the Tata Memorial Hospital RCT, I was shocked and puzzled at the detection rates that were documented in that publication. They were 30 to 50-fold lower than the detection rates documented in Mumbai a few years before. And at these numbers, 0.02%, they were effectively 0. So the Tata Memorial RCT was using a screening test that failed to detect precancerous cervical lesions. And I was very confused and perplexed as to what was going on. In 2014, a college friend of mine, who's an investigative journalist in the United States, Bob Ortega, used the U.S. Freedom of Information Act to get documents from the U.S. government pertaining to the Tata Memorial RCT. And that made everything much more clear. In examining the documents from the past, we found out that the Tata Memorial RCT began as a downstaging study. That it actually began as unaided visual inspection and was changed to visual inspection with acetic acid sometime during the first screening round. But although the screening test was changed, the performance of the screening test remained the same. The goal of the intervention used in this study was a downstaging goal, not a screening goal. Downstaging is an intervention that, by design, fails to detect precancerous lesions. Downstaging is an esoteric concept where it's thought that by simply detecting cases of invasive cancer at earlier, more curable stages of disease progression, you can lower cervical cancer death rates. You won't lower cervical cancer incidence rates, but you'll lower cervical cancer death rates. Now, it's important to understand that no competent physician would ever recommend or adopt a cervical screening test that by design does not detect precancerous lesions. Downstaging and direct visual inspection was the intervention that had been studied during the 1990s and that by 1996 had been found to be obsolete. Now, how and why we could get from a mindset like this to 1 year later funding a 15-year study to study an obsolete intervention is an important unanswered question. But what is answered is the difference between this number and these numbers. The disease detection rates achieved during the Tata Memorial Hospital RCT are radically lower than the 0.9% achieved during the screening test, because the intervention studied in the Tata Memorial RCT was a downstaging study. That the Tata Memorial RCT is published and advertised as a screening study when in fact it's a downstaging study is somewhat problematic. But the implications of this are very important to understand. This means that by design, the Tata Memorial RCT withheld valid cervical screening tests. And by a valid cervical screening test, I mean a cervical screening test that by design will detect precancerous cervical lesions. But the Tata Memorial RCT withheld valid cervical screening tests from over 151,000 women in both the intervention and control groups during the 15-year period required for enough women to die from cervical cancer to assess whether the obsolete downstaging approach, which by design could not prevent cervical cancer, might nevertheless reduce cervical cancer mortality rates. It's also unclear and probably unlikely that any of these 151,000 study subjects will ever receive valid cervical screening tests. The women in the intervention group have already received 3 or 4 rounds of downstaging, and they're not slated to get any more interventions. And the women in the unscreened control group, it's unclear whether they're going to be whether they'll eventually receive a valid cervical screening test or just one of the downstaging tests, which is not very helpful. Now, I know that what I have to say is very difficult to hear, but please keep in mind that those 2 previous slides are based on these numbers. And if anybody can give me another explanation as to why these numbers are the way they are, I'd love to hear it. Withholding valid cervical screening tests from 151,000 women for 15 years required informed consent procedures that were determined to be unethical by the U.S. Office for Human Research Protections. The U.S. Office for Human Research Protections is the branch of the U.S. federal government responsible for ethical oversight of medical research conducted or supported by the U.S. federal government. This office determined in 2012 that study subjects for the Tata Memorial RCT had not been given adequate information about the life-saving differences between cervical screening, downstaging, and no screening. But the question I'd like to put out to you is whether we really needed the U.S. Office for Human Research Protections to tell us that unethical informed consent procedures had been used. Because just think about it. Think about, hypothetically, a conversation between the principal investigator and a woman who was interested in enrolling in the study. The investigator would have to tell that woman that cervical screening is a scientifically proven, life-saving intervention that would significantly reduce her risk of dying from cervical cancer in the future. That's part of informed consent. You've got to tell somebody that. And then the same investigator would have to tell half these women that, congratulations, you've been randomized into a no screening control arm for the next 15 years. Now, told those 2 facts, what sort of person would agree to participate in a no screening arm for 15 years? As I've written in IGME, to suggest that Indian women would knowingly consent to be randomly assigned to more death instead of to more life is to suggest that Indian women are unimaginably stupid. So informed consent was a necessity to begin and to sustain these unscreened control groups. In 2013, the U.S. Office for Human Research Protections ended its review of the RCT without requiring Tata Memorial to notify the RCT subjects that their consent had been unethically obtained back in the 1990s. And I'm uncomfortable with this situation. I'm uncomfortable that the information known to OHRP and to Tata Memorial Hospital is not known to the study subjects themselves. And I just point out that probably at some point in the future, some or all of these study subjects are going to find out that their trust has been betrayed, and that the longer we wait to tell them, the more upset they're going to be. The plot continues to thicken. In 2015, the U.S. Office for Research Integrity is the branch of the U.S. federal government that's responsible for monitoring scientific misconduct in studies funded by the U.S. federal government. In 2015, the U.S. Office for Research Integrity launched an investigation into credible allegations that I had supplied that data falsification may have nullified the scientific validity of the conclusion from the Tata Memorial RCT that downstaging had reduced cervical cancer mortality rates. Now, I don't want to take the time to go through the data and the irregularities that I submitted. What I've done is I've included in this PDF file that will be available to anybody who wants it. I've included the two tables that I submitted to the U.S. Office for Research Integrity and that are now included in a publication undergoing peer review, so that anybody who wants to review the irregularities that I submitted to the U.S. Office for Research Integrity may. This shouldn't come as a shock to anyone. Richard Horton is the editor-in-chief of The Lancet. And last year, after a weekend-long meeting with the editors-in-chief of the world's other major medical journals, Dr. Horton concluded that half of the scientific literature is false and that nobody is ready to take the first step to clean up the system. We're not in a good place. But what this means is that if people like you and me don't take steps to clean up the system, we can't wait on anybody else to do it for us. So now the Osmanabad study. The Osmanabad study compared cervical cancer death rates among women offered VIA screening, HPV screening, and Pap screening to cervical cancer death rates among women offered no screening at all. Here is the Osmanabad RCT in a nutshell. Pap smears were associated with no cervical cancer death rate reduction. Only HPV screening was associated with cervical cancer death rate reduction. And the implicit assumption in these RCTs that there's nothing better than death to answer scientific questions, that death is the ultimate yardstick, that you can't argue with death because, after all, it's death. And the conclusion of the Osmanabad RCT was that the superior death rate reduction of HPV screening was caused by superior HPV test performance. Now, when you look at just this simple table, that's what everybody would conclude. There's a fundamental problem with this study, though, and that's that superior HPV test performance did not exist. Test performance is measured by disease detection rate. In Osmanabad, Pap smears actually had a higher disease detection rate than HPV tests did. Yet, Pap smears apparently did not cause death rate reduction, but HPV tests did. The central fundamental logical absurdity of the Osmanabad study is that effects resulted from causes that did not exist. I noticed that in the paper. I was mortified. How could this wind up in the New England Journal of Medicine, for crying out loud? You know, are they asleep at the switch? So I went and I used my 175 words to write a letter to the editor. And with the New England Journal, you have to be polite. And I wrote that the unexpected lack of correlation between detection rates reported for the screening tests and subsequent mortality rates requires careful consideration. Because you've heard the expression, not all correlations are causations, which is true. It's equally true that all causations are correlations. So if there isn't a correlation, there cannot be a causation. That was the point of my letter. Dr. Sankara Narayanan's response was shocking. He responded that HPV testing had a higher detection rate than that of cytologic testing or VIA is clear from our findings. What this means is that another zombie argument was at play in Osmanabad. The zombie argument in this case is that the number 1.0 is smaller than the number 0.9. I don't think anyone needs special training or an advanced degree to realize that that's an impossibility, that's an absurdity. But if you don't believe that 1.0 is smaller than 0.9, then you cannot accept the conclusions of the Osmanabad study. This is a zombie argument. It should have died immediately, but it keeps lurching forward because it serves several political purposes, one of which is money. This zombie argument launched a global marketing campaign for the Qiagen hybrid capture 2 HPV test. This press release came out simultaneously with the end of the embargo by the New England Journal on the Osmanabad study. And note here, Qiagen will donate 1 million HPV tests with a total estimated value of $30 million US. Again, using basic arithmetic, that means that the HPV tests cost $30 US apiece, which is radically unaffordable for women in Osmanabad. So this zombie argument launched a global marketing campaign for an HPV test unaffordable among the communities where death rates from cervical cancer have been measured. Take a long look at this slide, because if that's not exploitation, I don't know what is. The plot thickens when you know that in 2004, PATH, which is one of the members of the Alliance for Cervical Cancer Prevention, entered into a partnership with the manufacturer of the hybrid capture HPV test to market HPV tests across the world. Now, when I bring this up, members of the Alliance get very upset with me, because when you bring up the possibility of financial conflicts of interest, all of a sudden people can't hear you, they can't hear anything else. And I understand that, I really do. I'm very sensitive to that. And so when the members of the Alliance whom I'd share this information with would get upset with me, I respond, I would always, and I still respond, as I did in writing in 2007, that what PATH and the Alliance should do is fully disclose the terms of their partnership with Qiagen for public review. So that way we don't have to worry about it. Just make it public so we can review the relationships and satisfy ourselves that there's no funny business going on. And that was in 2007. I'm still waiting for an answer. But also note another implication of this zombie argument. The zombie argument that 1.0 is a smaller number than 0.9 also means that the Osmanabad study is the first study in world history to conclude that high-quality Pap screening does not reduce cervical cancer death rates. No explanation was offered for this unprecedented conclusion. Now imagine if the New England Journal had published the results of a randomized controlled trial that showed that smoking did not cause lung cancer. I mean, you'd think that somebody would say something. Isn't that a little unexpected? Isn't that a surprise? But the prestigious New England Journal of Medicine publishes a study concluding that Pap screening does not prevent cervical cancer, and nobody said a word. The zombie argument that Pap screening in Osmanabad did not prevent cervical cancer is exactly what the Gates Foundation wanted to hear. That conclusion provided a caricature of vindication for the central founding assumption of the Alliance for Cervical Cancer Prevention. So, in 2009, with the publication of the Osmanabad study in the New England Journal of Medicine, the research team in Osmanabad gave the Gates Foundation exactly what they had paid for in 1999. So getting back to this extraordinary study conclusion, how did this happen? I mean, how did a screening test how did Pap smears, which outperformed HPV tests, wind up not causing any reductions in cervical cancer death rates? That study was taken up by a team of researchers at the University of Pittsburgh, Marshall Austin and Qinchen Zhao. And they published a paper in 2009. They did an independent reanalysis of the Osmanabad data set. And they found that the apparent failure of Pap screening to reduce cervical cancer death rates was actually a manifestation of very peculiar statistical biases that were skewed in favor of the HPV test. Austin and Zhao said that they had no evidence that these irregularities were due to deliberate data manipulation, but everybody should come to their own conclusions. Now, when there's credible evidence, when there's credible suggestion of data falsification, there should be some oversight, some appeal that you can check on that. I mean, the Office of Research Integrity does that for studies funded by the U.S. Federal government. A peculiar finding from the Osmanabad study is that apparently it's not subject to any oversight whatsoever. It was conducted by IARC. It was funded by the Gates Foundation. That means that the U.S. Office of Human Research Protections has no oversight of this study. I submitted allegations regarding the study to OHRP. They said they had no jurisdiction to look into it. The U.S. Office of Research Integrity has no authority to look into the data analysis of the study. So this is human research apparently without any checks or balances. And that's a quite disturbing finding. Finally, I'd like to talk about the Tamil Nadu study. This was conducted, it started in 2000. It was the first one to end in 2006. It compared cervical cancer death rates among women offered VIA screening to those death rates among women offered no screening whatsoever. The problem with the Tamil Nadu study is that it established that this set of screening studies produced irreproducible results. The Tamil Nadu study, with this principal investigator, concluded that VIA reduced both incidence and death rates of cervical cancer. The Osmanabad study concluded that VIA reduced neither incidence nor death rates from cervical cancer. That, by definition, is a set of irreproducible results. Of course, Dr. Sankara Narayanan was challenged about this. This colleague wrote in a letter saying, you know, this discrepancy has to be explained. And the response was that, shucks, we just don't know. We can't figure it out. And sorry, you know, when this kind of question, when you get stumped by this kind of simple, important question, it's time for a little humility. The actual explanation is that, as it turns out, using death as a yardstick, which should never have been a component of these studies in the first place, using death as a yardstick, just at the end of the day, proved that death is a lousy yardstick. That the use of death as a yardstick just produced irreproducible and absurd results. So here are the three RCTs of which I've been critical over the years, and it's difficult for me to envision more egregious betrayals of basic scientific and ethical principles. And where do we go from here? In 2011, we did what's called a positive deviance analysis in Vietnam. A root cause analysis is something you do when something bad happens, when an airplane crashes, or when a patient dies from a blood bank transfusion. You do a root cause analysis to find out what happened, what went wrong, and what to do to keep it from happening again. A positive deviance analysis is what you do when something good happens. Vietnam succeeded in making a big dent in its cervical cancer problem. And so we did a positive deviance analysis by which you find out what happened, what went right, and what can you do to keep it from happening, to make it happen again. And what we found is that what went right in Vietnam was not technology. What went right in Vietnam is that the right people at the right time had their hearts in the right places. And specifically, in Vietnam, the leaders in that country were committed to the ideological goal of improving health outcomes as rapidly as possible among as many people as possible. So to keep good things happening in other places, I think it would be a good idea to get other leaders to buy into this golden rule, because they should be doing this in the first place. So I would suggest that the world would become a better place if leaders at places like IARC, the US NCI, and the Gates Foundation would embrace this golden rule and assimilate its policy implications. Now, you don't see the golden rule listed in the mission statements of the US NCI or the Gates Foundation yet. Maybe it should be. But then to assimilate the policy implications, I suggest that a Delphi exercise would be appropriate. The Delphi exercise has a strange background. It was developed back in the early years of the Cold War at RAND Corporation, which is a think tank in Santa Monica, California. And it originally was invented as a way of getting contentious factions of the US military to talk to each other about the impact of new thermonuclear weapons on warfare. The Delphi is a tool for structuring conversation. It allows and helps facilitate conversation among diverse and sometimes contentious individuals. And its two main characteristics are structured information flow and anonymous interaction. And those two main characteristics reduce the negative consequences that can come about when face-to-face interactions are used for group decision-making. And those include these well-known psychological effects of groupthink and bandwagon effect, halo effect, so on and so forth. Here's how a Delphi works. When I've organized these, I use this website that's maintained by the Wharton School of Business at the University of Pennsylvania. It's free, it's easy to use. I suggest all of you take a look at this, and we use it in my department at Kaiser Permanente for quality control. What happens is the Delphi exercise begins when you get a message in your email inbox, like you've been invited to participate in a Delphi exercise. You open the message, you get a link. You click the link, and you're taken to your own confidential spot on the Delphi website. And there you see a series of questions. You click on the questions one after another. This Delphi was conducted simultaneously in Vietnam, Guatemala, and Mexico. So it was conducted in 3 different languages. So you go there, you click on the question, you read the question, you enter your answer. And then once you've finished answering all the questions, you can go back to the website, and you get to see what everybody else has answered. So you read the responses from all the other participants in the Delphi exercise. And after you've read everybody's responses, you answer the same. You have an opportunity to comment on the responses and to modify your own if you'd wish. The important thing to know here is that you can't tell the author of any given response. So the information is anonymous. And this allows people to more easily change their minds and revise their positions and to critique the positions of others. The Delphi that we wound up using for those 3 countries wound up with 11 questions. And this is a proposal I submitted as an invited editorial in the Journal of Cancer Research and Therapeutics in 2014. And it goes through the 11 questions. But the main questions that are addressed in the Delphi are these four. And notice that, I mean, some of these questions are quite important. For example, will the introduction of HPV vaccines accelerate or decelerate reductions of cervical cancer rates in your country? That's a question that's of fundamental importance that really nobody's discussing. And the goal of this Delphi is to use the Socratic method for simulating the policy implications for the Golden Rule. Because the Delphi fundamentally recognizes that the single biggest problem in communication is the illusion that it's ever taken place. And this is a real problem. I think all of you can appreciate that in your daily lives, in workplaces and other places. And so I'd like to conclude with a proposal. I'll be happy to organize a Delphi exercise for cervical cancer prevention in India. And I invite today this institution, King Edward Memorial Hospital and Tata Memorial Hospital, to participate in this. We can begin once I get email addresses for 6 or 12 participants, and we can conduct the exercise online and then come back here and talk about the results face to face. Thank all of you for your time and attention. It's been an honor to be here.
Thank you, Dr. Suba. I described your oration as likely to be provocative, and I guess I was not very wrong. The plan is to, before opening it to the audience, of course, to have two individuals who will be responding or discussing Dr. Suba's presentation. The first individual I would like to invite is Dr. Rajendra Padwe, who is the director of the Tata Memorial Center, one of the leading, I would say, a rare surgeon who has done research in very fundamental issues, well known for his work in breast cancer, especially the timing of breast cancer surgery, also an alumnus of this institution. So I will hand over the mic now to Dr. Badwe to respond.
I must express, as it is an ethical norm, to declare the conflict of interest, and I am one of the investigators in the study that has been shown just now, so that's a major conflict of interest. And it would have been ethically sound if our dear guest had also declared his conflict of interest, that he has been the treasurer of Papua Society of Cytopathology and presently is the chair of the Budget and Finance Committee for the Papua Cytopathology Society. Let's come to the study that we looked at, and I have a few comments related to that. The study was presented to the NIH for an R01 grant. We got that R01 grant. Prior to that, there was a review by ICMR looking at feasibility of pap smear in India, and there is a publication from Usha Luthra in BMJ stating that it is not feasible to have pap smear being implemented across the country. The third implication is that the OHRP, when they looked at, Dr. Suba mentioned about 2012 and 2015, about the ethics of conducting the test as well as falsification of data, and he didn't conclude as to what was the finality of that investigation. Both the investigations have concluded from OHRP saying that there is neither any falsification of data, because all the data was put forth, it is available at the NIH site as the response to these queries. And there is no unethical conduct as far as the conduct of trial is concerned. Finally, when we looked at the results show a 31% reduction in deaths related to cervical cancer and a 9% reduction in all-cause mortality. I would challenge anybody to look at the results of any screening trial that has ever been published, randomized screening trial that has ever shown a reduction in all-cause mortality as well as cause-specific mortality. This is the first and the only trial. This was presented as a plenary session talk at ASCO. My colleague, Dr. Shastri, made that presentation. ASCO, for your information, receives about 30,000 abstracts for their meeting. About 3 or 4 are selected for plenary. This was one of those 3 or 4 out of 30,000. We received a standing ovation from more than 35,000 oncologists across the globe for a fantastically run trial saving lives. When implemented in India itself, would save 22,000 lives annually for women of India. If implemented anywhere else globally, for developing world would save 78,000 lives annually. And this was implementable by healthcare workers who were 10th pass. 10th pass workers trained for 2 months. Solid results. The only robust evidence for saving of lives was screening of cervical cancer. Both those done, what was remarkable is that after the presentation, in the press interaction, the scribes from US had this very remarkable suggestion that there are parts of US where PAP is not implementable. This is an excellent alternative for the United States. Having said all that, when it comes to the trial results, the day we had the difference emerging, reaching statistical significance, this data was shared with Department of Health, Union Government of India, Department of Health, Maharashtra State, and as we talk, 15 states have adopted VIA. All the ASHA workers and health workers have been trained, and we already have 15 states in India implementing VIA for cervical cancer screening. The ground level practices for cervical cancer screening did not exist. There was no cervical cancer screening prior to 1997, 1999. And you might say that the end point of a study is that we did see a slide showing that from 24-25, the incidence of cervical cancer has reduced to 6 per 100,000 in United States. And in Vietnam, it has reduced from 25-26 to 11. Both have been credited to cervical cancer screening by pap smear. I'm not saying that pap smear will not do it, but I want you to look at data from Bombay Cancer Registry. We have no pap smear, we have no VIA when this data came in, we have no screening, we have no prevention. The data for cervical cancer incidence in Mumbai in year 1972 stands at 27 per 100,000 per year. The data for cervical cancer, as I got it day before yesterday from the Bombay Cancer Registry, stands at 8 per 100,000. My suggestion that reduction from 27 or 26 to 8 without doing anything. There is a reduction naturally happening with improved personal hygiene. Our Muslim brethren, whether in Mumbai or in Barshi, In Barshi, the incidence still stands at 28 per 100,000. But the Muslims in Mumbai have an incidence which is 4 per 100,000. Muslims in Barshi have an incidence which is 4 per 100,000. We are looking at personal hygiene. My interaction and suggestion to the Union Health Minister is provide running water, good sanitation and personal hygiene to every individual in rural India where it is needed. Half the diseases will be gone. Had HPV vaccination being introduced 20 years ago, we would have created the HPV vaccine. Why are we spending money? Till the time prevention happens, we may have to do something. Let's do it low cost. This is doable, shown to be implementable, implemented, we'll have results. We already have results of reduction from 26 to 8. At 8 per 100,000, disease does not require preventive and screening strategy. Screening is required for common diseases. If I were to ask in Bhuleshwar, should I be looking for tiger? It is a foolish exercise. There are many other common diseases for which we need to look at for screening purposes. But the trial was performed essentially to see the efficacy and its implementability in rural India, where the routine thing like VIA would be taken care of without any problems. Problem created, that we may go to population, create that there is something not right, detected. Presently, every state government is sold a hub and spoke model for primary care, for tertiary care, and every spoke in every district hospital will be able to take care of all the patients who are detected like this. I don't see any reason why efficacy of one procedure needs to be coupled with deprecating some other procedure. We don't need to. Let there be a cafeteria choice and people can take. Somebody wants to have that, I have no problem at all about it. Somebody wants to have VIA, that's absolutely fine. You want to have HPV vaccine, but let there be knowledge that what each of them mean, what they cost, and what is the present perception of risk. It can't be that one of the greatest film actresses says that I need to have bilateral mastectomy, that every woman should have bilateral mastectomy. That's not right. Perception of risk is required, reality of risk perception, and reality of risk perception is that the incidence of cervical cancer in city of Mumbai, the same is true for city of Delhi, Bangalore, Chennai and Kolkata. It's under 10. Incidence of cervical cancer less than 10 per 100,000. How different is it compared to 6 in the United States? Without doing anything. We have not spent any money. Just plain, simple, personal hygiene. My advice would be that. Thank you very much.
Thank you, Dr. Badwe. I would request you to wait here because I suspect there will be responses in the question and answer session. But before we do that, I would now like to invite our second discussant, Dr. Amar Jasani. Amar is, I don't know how to describe him, he's a doctor, but he gave up medicine some time back, and I think he did a good job at that. It's a good step. Amar is now into ethics. He is now the editor of the Indian Journal of Medical Ethics. He teaches ethics in many institutions in India abroad. And I would now like to request Amar to respond, following which we'll open it for discussion.
Thank you very much. I'm here as an editor of the journal where Dr. Suba's paper was published in 2014. And I would like to discuss more in detail about what were the considerations that led to the publication and many other issues related to the points that he has raised here. But before I go on to that, I must declare that I once upon a time, for 1.5 years, that is between 2006 and 2007, I sat on the ethics committee of the Tata Memorial Center. And it was a really great experience for me. This is the institution which has been doing a massive amount of pioneering cancer research in India. And as a member of the ethics committee, we had to work really hard. I haven't seen the ethics committee so far. And I have been with Sri Chitra, I have been with the Nizam Institution, ethics committees and all the other big biomedical institutions. But here was the institutions where sometimes we had to sit every 15 days. And in one sitting, we had to tackle more than 20 agenda items and large number of clinical trials and the amendments in clinical trials and all. So I learned quite a lot. This was also the period when the Bombay trial was on. The only thing that I can say that although I knew that trial was on, because in Indian Journal of Medical Ethics, I think the first time a comment on this was published by Sandhya Srinivasan in 2003 or 4, and there was some discussion on that. However, I never had an opportunity to get the protocol to review and understand, what were the exact issues. I came to know more about it after Dr. Suba's article was published in Indian Journal of Medical Ethics. So that is, I think, a background in my declaration. The one important part of today's meeting, which I feel really very proud of as a person who is in the field of bioethics, is that I think for us in India, we are now setting a new tradition where we can sit together and discuss our own research and debate and deliberate. I think debating and deliberating is fundamental to the development of ethics. If you see the way the bioethics has developed in USA, and you read, American medical journals, you'll find that the doctors and scientists come forward reviewing and critiquing each other's paper. A number of large clinical trials which have been debated, sometimes very sharply, more sharply than what we have been doing on the subject. And yet, nobody getting any kind of witch hunting on anybody, or hanging anybody and saying that, well, you get out of this. There is a lot of respect for good work people are doing. And yet, when we are doing research, we do follow certain paths which may run into controversy. So I don't think we are belittling any scientist or science here, but we are trying to learn from what we are doing. And I think that is a good interactive method, or what they call Socratic method of learning ethics. And if this tradition strengthens in coming time in India, I'm sure we will be doing more introspection and interacting with each other in a very good critical manner. That is the role of the journal too. And the medical journals in India, unlike, say, when you read the Lancet, where Lancet editor can make a comment about India, slashing health budget and then coming out with his own comment, or India's, the way India looks at the sexual assault and rape and other things. Well, why Indian medical journals are not able to reflect on these issues and say that what is the role of medicine and health system in this kind of thing? So that way I feel as an Indian Journal of Medical Ethics, we were quite keen on getting into the issues where some critical questions are asked. Dr. Suba's paper required, I think it went on for peer review for almost 9 months. He was very, very patient with that. And there were several people who did the peer review of the journal, including one person who said that it should be rejected. And I remember meeting that person in Geneva in a World Health Organization's meeting, and I asked that, why do you think that he should be rejected? He said, no, issues are very correct, what is raised there. But the major problem was that this was the research which may perhaps help a large number of women. VIA, the visual inspection with acetic acid, if that can be universalized, used as a very cheap tool for detecting precancerous lesions, then it will have a very tremendous impact. And I agreed. I said, yes. There is nobody is saying that the the intentions were bad. Intentions were excellent. If you look at Tuskegee trial, when it was started, those of you who have come to say, some of my ethics training sessions, we show a film called, Miss Eva's Boys, where the whole thing starts with an excellent commitment, saying that we want to prove that the black people suffer from the syphilis in the same way as the white people. And they were fighting ideologically and ideally against racism. Like, doctors were highly committed and they were very sensitive to the black people. And yet, at the end of 40 years, the world was shocked that these are the same good doctors with so much of sensitivity for black people had done a study which allowed the black people to develop syphilis and die. I think this is a crux of the issue for me as far as the bioethics is concerned, that this could happen to anybody, any scientist. So here is also that the reviewer who said that yes, they've had a very good intention, so I do agree. I also recollected at that time, and I used that case study quite a lot in my teaching, again, concerning carcinoma cervix, done in India with Indian government funding. This was a study done in from 1975 to 1990, where they wanted to understand the natural history of the cervical cancer, to understand that which are the precancerous lesions convert into the carcinoma in situ. And they recruited more than 1,000 women, and they observed them without giving any intervention for 6 years to understand how many of them who are having precancerous lesions they convert into the carcinoma in situ. That also had some amount of discussion. Unfortunately, it did not raise as much as it has done here. I praised Dr. Suba's persistence, and he came to the National Bioethics Conference in 2014 December. And he has come again and delivered this lecture, so I think we are having more discussion on the subject. But that research was also conducted with a huge devotion, saying that if we find out which are the lesions which will convert into the carcinoma situ more, then we'll be able to conserve resources by intervening in those women where those lesions are going to convert into carcinoma early. So this is how entire thing was conceptualized. So I would not go into the issue of intent. Intent were excellent. Do this intent really translate into a good ethics or not? I think that is the debate as far as I'm concerned. And I find that there was a problem. You can't recruit women and observe them for 6 years to find out whether they convert into carcinoma situ or not. Just as the Tuskegee trial, you cannot recruit black people to find out, how, syphilis plays out for the coming time. And the end result is either death or, something. That was what was in syphilis, and here the end result was development of carcinoma in situ when they were intervened. Now, this issue has certain connection with this trial also, where Dr. Suba kept saying that 150,000 women were provided no intervention. That means for 15 years, or for whatever the length of trial, I mean, at 3 different centers, the lengths were different, where the no intervention arm were not screened at all. When the screening has been definitely, regarded in the scientific world as the requirement. I think this is an area that really moved me, and that's how we went ahead and published this paper. And I'm very happy that this kind of debate has taken place. The last thing that I wanted to put before you can have a larger discussion is that was this kind of study possible ever, say, in the United States? I would like to ask, because I'm not an oncologist. My own technical understanding is very, very low. And Dr. Bhatt has said that there are big black pockets in USA where even pap smear is not available, and it is not a standard. So would they have done, with NIH funding, because money came, both NIH and Gates Foundation was from the US, would they have been permitted to conduct this study in the USA because there are some pockets where the standard of care was not pap smear at all? I would say no. It wouldn't have happened there. They wouldn't have allowed. Because they know that you cannot sacrifice some people with good intent now in order to do good for the millions of women later on. I mean, this is what happened in the 1975 to 1990 trial, where women were having, the precancerous lesions, they converted into carcinoma in situ. This is not allowed because they are under your care. They are part of as a participants in the research. And you have a higher ethical obligations for them as compared to in the normal clinical practice. So they would not have allowed that. They would not have allowed the black people, black women who are not having pap smear to be observed for 15 years to find out, what is the better, VIA or. So this perhaps can also be looked at as a project where some kind of ethics dumping took place or double standard by the funders. I think that's how Dr. Suba's focus. So these are US funded trials, and he has been demanding in the US that US should acknowledge this, that they did something wrong by supporting it, and should apologize in the same way, right, as they did to the Tuskegee participants, and should make the funding to ensure that all these women who were not screened, money is made available for screening and providing intervention so that they really get what they should have got under the trial. I think these are the key issues around which the most of the ethical debate on this subject is coming. There are a lot of other technical aspects and a lot of good achievements, as I said, there, and they are not to be belittled. I think they will be used historically in coming time as 1975-90 trial of natural history of carcinoma cervix had really helped in a big way in setting up the whole program on the carcinoma cervix in India. Same way, I'm sure a lot of women will ultimately benefit from it, but those who really participated and who were denied the care, I think we need to look at them and also see that if there were real errors in terms of ethics committed during the trial. Thank you.
Thank you, Amar. We would like to now open this out for debate and discussion. But before I do that, yeah, sure, we'll come to you. Can I ask the people on the dais, would you like to briefly respond to the points made by the others? Is there, would you like to do that? Okay.
Dr. Badwe, thank you for coming today. And I've just got a couple of questions. Your study, was it a study of downstaging compared to no downstaging, or screening compared to no screening?
The study had the endpoint of mortality reduction. Downstaging was a surrogate marker to be proven that we may look for mortality. But the study was aimed at reducing mortality related to cervical cancer. That was the endpoint.
So it was a downstaging study?
It was not a downstaging study. Downstaging was a necessary surrogate marker to look for mortality. The endpoint of the study was reduction in mortality. The aim of the study was reduction in mortality.
Thank you. My next question is,
Dr. Suba, I would just like to respond to this.
Well, I have a request. Could you just introduce yourself for the audience, and then, of course, yeah. Yeah, sure. There are two mics there.
My name is Sudeep Gupta, and I'm a medical oncologist at Tata. I just need to respond to you. You repeatedly characterize the test as a downstaging test. There is nothing about any test that characterizes it as either downstaging or screening. Mammography can be in different contexts used either as downstaging or as screening. It is the endpoints of the study that you were alluding to, and as Dr. Badwe rightly pointed out, the primary endpoint of the study was reduction in cervical cancer mortality. So you cannot characterize a test as a downstaging test.
Well, then my follow-up question is, how do you explain the extraordinarily low disease detection rates for your intervention?
Because the
precancerous detection was not the endpoint. 75% of CIN1 and CIN2 are reversible. They disappear over a period of time. The primary goal is to reduce mortality. That's it. That has been proven beyond doubt. Statistical significance, reduction in cause-specific mortality, reduction in all-cause mortality. There is no such robust evidence for pap smear.
Thank you very much for coming all the way to tell us what we need. Could we have that slide which you kept on repeatedly putting up, I think 20 times in your presentation? Can I see it once again, please? Which showed that in one of my studies, the detection rate was higher as compared to the second study, right? That's the one. Thank you. Thank you. That's the one. Yes. I think your representation of that particular slide is either ill-informed or mischievously misrepresenting. Because it very clearly says in the methodology of both those studies, yes, the mic is on. It very clearly says in the methodology of those two studies, the first one is a hospital-based study. The hospital is the preventive oncology clinic where we get referrals. The second one is a community-based study. For the audience, I'll just explain. If I were to take a team of people in a community to find out how many cases of tuberculosis we have in this community, the answer would be 5 out of 1,000, 2 out of 1,000 or something like that. But if I were to do the same thing in the TB OPD of this hospital, how much would that be? It would be much higher. And that is explained in the methodology. I think you are purposely, mischievously been misrepresenting it all the time. I'm not finished. I'm not finished. I would, sir, come to you. And it's a journal of medical ethics. And pardon my saying so, any journal, and all the more a journal of medical ethics, should have looked into a contentious paper which you said was reviewed for 9 months, and then decided to invite the authors of the publications where allegations are being made to respond side by side with those so that people get a correct view, not just one point of view. Will you agree with that? And you didn't do it. Thank you very much.
Dr. Shastri. It's on? Thank you for clarifying that. So you're saying that these numbers, 0.02%, those are the actual benchmarks for Mumbai. Thank you for clarifying that. Then my next question for Dr. Shastri and Dr. Bhagwat. In 2007, The Lancet published the results of the Tamil Nadu study, showing that one round of VIA apparently caused 25% reductions in mortality and incidence. Why didn't you stop your study at that point?
I think we need to reiterate what medical literature and how learning takes place. You pick up any large intervention that has changed clinical practice, any large intervention that has changed clinical practice, it comes in one trial. If it is robust enough, then it is implemented. But if not, it needs to be reproduced at least in one more trial before it is implemented as a routine practice. We had finished our intervention by then. It was only a routine follow-up that was happening. And that's the reason why it was not done. I repeat again, the day the second trial showed a difference, the Union Health Ministry, the State Health Ministry were informed, and as we talk, more than 15 states have implemented VIA, and all of them are getting VIA as a routine screening in rural parts of India where it is required. I again repeat, cervical cancer screening in cities of India is redundant. With an incidence of 8 per 100,000, it is redundant.
Okay, so we are going to open this out to the audience now. Amar, yeah, okay.
I would also like to
Okay, Dr. Shastri, one second. Let Amar respond.
To both Dr. Badwe and me.
Sorry?
The question was directed to both Dr.
Okay.
Badwe and me. I think I have business to answer. I would also like to tell the audience that the OHRP, what Dr. Suba has been continuously talking about, was an investigation instigated by Dr. Suba. They investigated us for almost 6 months, and it's there on their website. It's a US government transplant website that puts everything up on the website. What are their determinations? What actions have been taken? What, at the end of the investigation, did they find? Dr. Suba never talks about that, what they found at the end of the investigation. He said that they never told him that. They are there on the website. You just go and give a search for OHRP, and you will find what are the determinations on the website. There. The question of research integrity, which Dr. Suba talked about, and there was an investigation of research integrity also on this trial. And I must tell you that they not only exonerated us, but they invited one of us for a meeting of the research integrity in the US to discuss these kind of cultural, multi-country cultural issues related to ethics and related to research integrity out there. So they value our contributions to science. 3, I would like to inform you, Dr. Suba, and I'm sure you know it already, despite your cytology program that you set up in Vietnam, the government of Vietnam today, and please search that on the web too, is taking up VIA screening for the population. Thank you.
Thank you. Amar, you wanted to respond?
Just a very brief response to how the debate on the subject in Indian Journal of Medical Ethics has taken place. I think all of you, who are part of this study had quite a lot of opportunities to write in the journal. And if you go on the pages of the Indian Journal of Medical Ethics, you'll find that all the reviewers that have come so far have been very scrupulously published. In addition to that, we also made a lot of efforts to encourage debate by inviting both national as well as international bioethics experts to write on the subject. I think you will find their papers, including Professor Ruth Macklin, who is one of the topmost bioethicists in the USA, her views on the trial and the debates on the subject. The only humble request that I would like to make, and many of you who read medical literature, particularly British Medical Journal, would be aware that there have been a lot of debate about what is called data sharing, and ensuring that when we do clinical trial, we make anonymized data available to the larger number of experts to reanalyze and relook at it. There was a very good debate and discussion that came in BMJ, where they went back to the study 3 to 9, where there was an anti-psychiatry drug, and they relooked at the data of the clinical trial, and they found that the way data were analyzed and published, there were a lot of problems. So this is a live debate and live discussion in the bioethics as well as medical science, that what we are doing as scientists, we may always not be completely unbiased. You can definitely say that as a bioethicist, we are not unbiased people. Our job is to pass a judgment, to say what is right and wrong. And we may also recognize a lot of gray area between right and wrong. But we do stick our neck out and say that there is some problem here. And we may sometimes be wrong. We may be, criticized, so there is no doubt. I mean, in philosophy, and bioethics is a discipline of philosophy, where criticizing in the sharpest term is very much acceptable. I think in medicine, we are not so tolerant to criticism. If you read in Economic and Political Weekly, I remember Professor Richard Kesh, who took, I think, a couple of ethics training sessions in Tata Memorial Hospital when I was a member of the ethics committee. When I gave him to read Economic and Political Weekly, he said, "My God, I have never seen this kind of discussion where the attacks on each other, were so sharp, because the differences in the policies, economics and all they are sharply debated. But medicine doesn't do it to that extent, and we are very polite with each other. But in bioethics, we are quite used to. So my suggestion would be that if you would like to get out of the controversy, be more transparent. Make your data available to more experts who come with a good reanalysis plan, and let also look at them. Because when we claim that we are the great and our data are good, we need to have more confirmation being done. I think this is a trend that is emerging at international level, and it is going to engulf us in coming time. It may take, we can resist it for some time through our whatever effort, but sooner or later, science will have to become more transparent and more engaging with the public than it has been in the past.
Okay, so we have lots of hands. I have a request. So firstly, identify yourself, be brief, try not to repeat what has already been said, and we'll try and make it as representative as possible. Dr. Mitra, just before you, I think he's been raising a hand, so just give him an opportunity.
So Dr. Suba, in India we have a culture that guest is the god. So Atithi Devo Bhav, so you are the god for us as a guest. But let me tell you, when you were making your presentation, I had a comment that you sounded more like a lawyer who is vociferously trying to save a client rather than presenting the science. Because see what happens, when you say that the plot is thickening, it is sounding like a Hollywood blockbuster rather than science. So that is one, because what happens when scientists wear the cap of activist, then their credibility goes down. And therefore we have to be very careful in our public appearance. That is one. And second thing, I have a serious objection when you compare.
Okay, so let's please hear him out.
Let me present the question to you. The question is that you have repeatedly said that the controlled arm women were allowed to die. I have a serious objection to that. The reason is that in a population where this study was going on, where one arm was receiving intervention, the other arm was a control arm, the third group was who were not part of the study. And let me tell you, the control arm is an active surveillance arm. It is not an arm where women are allowed to die like the real world who are outside the study. That is number one. Number two, you have been always comparing the non-screen group with the smoking, that it is as unethical as running a smoking versus no smoking. That means you are saying that non-screened women were akin to the smoking, which is incorrect, because fatality rate of smoking is 1 in 3.
Can you just try and be a little, there are lots of hands, lots of people,
correct.
So please try and control.
Your comparison is malicious. The reason is that only in the non-screen group, 8 out of 100,000 would have got cancer. But in smoking, 1 in 3 would die because of smoking. Even Tuskegee was an arm where the patients were being accrued, and this arm, they are healthy women. And what I will end with, Mahatma Gandhi said, if you want to find a solution, go and live where the problem is. We know the problem better and we know how to solve it. Thank you.
Okay. Dr. Mitra. Yeah.
Dr. Dasani said that watching women getting cervical cancer in black women was unethical. This is exactly what is happening today with TCIs in breast cancer. Because we don't know which breast cancer will become a real cancer. TCIs is in situ cancer. We don't know which in situ will actually become a real cancer. So what Dr. Dasani said was unethical between 1965 and 90 whatever is happening in breast cancer today, in the enlightened day of today, because there is this serious problem. Because if you treat every TCIS, you are unnecessarily causing a mastectomy, unnecessarily giving radiotherapy, unnecessarily making the patient a cancer patient. So what Dr. Dasani said is unethical. Is happening today's enlightened, transparent society in breast cancer.
Okay, let's have, yeah, Tina.
Well, first of all, I'd like to congratulate GSMC for this wonderful interaction. I'm Dr. Reena Vani. I'm a professor of obstetrics and gynecology, a woman dealing with women, and I'm also a founder member of the Cooper Hospital Bioethics Unit and a sister concern of the same thing. So I'm representing both sides. There are no sides here. What I'd like to say, first of all, I'd like to congratulate Dr. Badwe on putting it in a nutshell. He has pointed out the conflict of interest over here. It is a question of perspective. A pathologist will always want to praise the pap smear because he thinks that's his baby. Dr. Shastri has pioneered VIA. He thinks it's very good. That's something he has pioneered, and he was praised in Mumbai Mirror for making vinegar save women. As a gynecologist, I would like to also say that Dr. Badwe said we need not screen in Mumbai. I would not agree with him on that. I feel that this reduction to 8 is not only because of personal hygiene, it is because of increased awareness, opportunistic screening. I'm in the public healthcare system, and I feel what you said, sir, about cafeteria approach is absolutely right. We have to make awareness and we have to make the methods available to women. So I think today there is no winner or loser in today's debate. I think I am very happy we have focused on this issue and we have to make screening available to women. And the very fact that Dr. Shastri's trial was ratified, rigorously grilled and gone across by many, many international organizations, I would say we have to give him credit for that. And we do have to see that the perspective of how the data is presented makes a huge difference. So I think all of us should keep our minds open and take things with a pinch of salt and do not get carried away when people say zombie argument. Thank you very much.
Good afternoon, I'm Dr. Jayashree Joshi and I'm very much interested in preventing cervical cancer. One technical point I just wanted to bring to the notice of Dr. Suba, that if we wanted to show any effect at all of VIA and had carried out the study in rural India where pap smears are not available, it would not have been possible. I think only because it was conducted in Mumbai and with such rigorousness, they were able to follow up. Otherwise, when you don't have a follow-up, you can't come to conclusions. And that is the reason why VIA has become available to women who have no screening method at all.
2 or 3 questions. We need to wind up in about 5 to 10 minutes at the max. We are already beyond time. So let's, yeah, okay.
Dr. Suba, this is Priyanka from Hindustan Times. So we wanted to understand, do you think implementing of the VIA testing that India is doing now will be incorrect according to the assumptions that you have about the study?
Could you repeat that?
I'm asking that the implementation, India is implementing the VIA program now in 15 states, as Dr. Badwe has already said. Is that incorrect, or do you think that is wrong, depending on the results of the study?
Okay, suggestion that we take some of the questions and then we give you a few minutes at the end to respond, because we need to try and wind this up in the next 10 minutes. Anybody from yeah, okay.
My name is Pramesh. I'm a thoracic surgeon, far removed from cervical cancer. But again, declaring my conflict of interest, I work at the Tata Memorial Hospital, which actually conducted the study. Good presentation. Unfortunately, sounded more like a Michael Moore movie, if you've seen Fahrenheit 9/11. Very biased in its interpretation. 3 main reasons why I feel so. I think your insistence on having detection of precancerous lesions as an endpoint by itself is fundamentally flawed if you understand the research methodology that goes into screening trials. The only valid endpoint that you can look at in a screening trial, it's not survival, it's not progression-free survival, is mortality. It's a fundamental basis of any screening trial, and I'm disappointed that somebody who's so actively interested in cervical screening has been unable to understand that. Second, if you look at the ICMR report of in the 80s, which looked at the feasibility of doing pap smear in India, the conclusions by an unbiased Indian Council of Medical Research, Government of India collaboration was that if you were to multiply the number of existing cytologists in India by 25-fold, you would still be able to screen only 1/4 of India's women, and that too once in a lifetime. Clearly saying that it's practically impossible to implement in a country like India. And proof of principle by doing it in a small city in Vietnam doesn't really translate. I think India is slightly bigger than Vietnam by population. Finally, my point about cost effectiveness. If you had read through our editorial or our response in the IJME, the Harvard School of Public Health conducted a cost-effective analysis comparing pap smear, VIA, and HPV DNA testing. The cost per life saved of VIA was $460 US. The cost per life of HPV DNA was 25 times more at $11,500 US. And the cost per life saved of pap smear was actually more than what HPV DNA testing would have actually cost. And in a very cost-sensitive healthcare situation like India has, to suggest that either HPV DNA or pap smear could be universally implemented is being extremely naive. Thank you.
Okay, Pramesh. You lost my support. How can you not like Michael Moore movies? But anyway, Ravi.
I'm Ravi Dugal from the Anusandhan Trust. I'm not a medical doctor. I'm a mere sociologist. My question is that, why are we not also talking, while we do these clinical trials, why are we talking about greater transparency and social justice for the people who are part of the trials and so on? I think that's a very critical question that we need to also address when we do clinical trials and so on.
Okay. Any other questions, comments? Before you, because you've already had your floor. Okay, Meena?
Yeah.
Hi, I have a question for Dr. Badwe. If VIA and pap smear are known in their efficacy, in their specificity or whatever, and all that you were doing is to check whether VIA can be conducted in rural India, what was the need to have a control arm of no screening? You test all women and you see whether it is viable or not. You can test it with a standard pap smear if you have to. But what was the need to have a no screening arm? I think that was highly unethical in your trial. And I don't think any of you all have addressed that. Well, I've just given that, oh, government of India is so great and international bodies have done this great thing. But well, you have to answer this very basic question. What is the need of just observing these women like that?
Your first statement that efficacy of VIA and pap smear is proven is wrong. It's false. The evidence that is required in medical practice to show that this is effective is a good, robust, randomized trial. Lest we will be doing 20 procedures which are done in the United States and withdrawn. Mammography in today's paper, withdrawn. Why is it withdrawn? After 20 years of practice, the evidence came up that it is useless. It is harmful. It is exactly what I'm trying to tell you, that surrogate marker that something is detected does not necessarily mean the lives will be saved. I'll give you an example. I do a physical examination on 100 or 1,000 women walking on streets of, say, United States for breast examination. I'll pick up 2 cancers. Women are ostensibly normal. I increase the sensitivity by doing mammography, that number 2 will become 4. I do the sensitivity greater by doing MRI, that 4 will become 8. God forbid nothing should happen to these women if they were to die of vehicular accident, not diagnosed with cancer, and if I were to increase the sensitivity of detection by looking at, please don't misunderstand, from one end to the other, the number of such experiments have happened. The number of cancers are approximately 240 in 1,000 women. Increasing sensitivity does not mean we now know that change from physical versus physical plus mammography, a trial comparing increased sensitivity, does it save lives? 20 years follow-up, no saving of lives. But 30% excess detection done. Excess detection does not necessarily mean efficacy. If I were to walk through that little metal detector in airport, if it were to detect past or present corrupt thought in human mind, I wonder who will be able to walk through it. I will not be able to walk through it. But we are not looking for a single corrupt thought. We are looking for somebody who can pick up AK-47 and kill. We are looking for a terrorist. We are looking for a cancer that will kill, not a non-cancer. Look at it some other. I will give you the ethics point of view. If increasing sensitivity does not save lives but picks up more cancer, what does it mean? That increased sensitivity cancers are non-killer cancers. If I am a market force person, what am I selling as a doctor? I am selling immortality. Isn't it? I don't want my patients to die. Here is a set of individuals who will never die but have cancer under microscope. I want to treat only those. 10 years down the line, I will be looked upon as the most successful doctor. Anything that he treats never dies, but in the first place they were not supposed to die. Market forces completely exploited. Thank you very much.
Okay, I think we have to conclude. We are well beyond time, and before we wind up and Dr. Badwe has to leave, everyone has to leave, I just want to once more say that the talk, as I said, was provocative, and you succeeded in provocating. But I think, as Amar said, this is perhaps rare and historical that we have sat together for 2 hours, debated, discussed, deferred, and perhaps this is a good beginning. I now would like to call upon the organizers to would like to propose a vote of thanks. Thank you.
Thank you, sir. I would like to appreciate all the speakers, the discussants, and the chairperson for the handling of the issue so sensitively, so graciously, and so scientifically.